everybody. Welcome to the UCIP, University of California University for Prediction Technologies hackathon. So it's the Opioid Hackathon 2018, and for all of you that are new and just like coming in today, and everyone this whole weekend who has participated in the multiple events, thank you so much for being here. We really appreciate coming out and participating and listening to all of the very innovative solutions here today and listening to our speakers on Sunday. So I just want to thank you all for coming out. We really appreciate it, and we're so excited to have you all here. And so with that, welcome to the second round of judging. We're really looking forward to seeing the finalist solutions, and thank you to everyone who's worked so hard this weekend. So now I'm going to introduce today's judges for round two, and we're so fortunate to have their expertise and knowledge here today at the hackathon. So our first judge is Letitia Ingram, who is Research and Data Coordinator for the Office on the Office on Trafficking in Persons within the Administration for Children and Families at the U.S. Department of Health and Human Services. So thank you, Letitia. Next, we have Dr. John Ives, who is the Director of the Brain, Mind, and Healing Program at the Samueli Institute. So thank you, Dr. John Ives. Third, we are pleased to have April Rivero, who is the founder and executive director of the National Coalition Against Prescription Drug Abuse. Thank you so much, April. Next, we have Dr. Bharath Chakravarthy, the Vice Chair of Research and Academic Affairs in Emergency Medicine at the UCI School of Medicine. Thank you so much. And fifth, we have Dr. Chen Li, who is a professor at the University of California, Irvine in the School of Information and Computer Science. And last but not least, we have Dr. Sean Young, PhD, who is our hackathon host and the executive director of the University of California Institute for Prediction Technology, or UCIPT, and he's also an associate professor of family medicine at the UCLA David Geffen School of Medicine. So thank you so much to all of our judges today. Thank you. Yep. And now I'm going to pass the mic off to Dr. Sean Young, who's going to talk a little bit more about summarizing each of the tracks that we had today, or had this weekend at the hackathon.
All right, welcome everyone. I'm Sean Young. Welcome, as Claire said, to the final round of UCIPT's the Opioid Hackathon 2018. For those of you who are just joining us, you are at, it's been about 36 hours now where teams here have been competing against each other, many of them without sleep or very little sleep. We have some pictures of people crashed out, drooling on couches, working together and competing against each other to develop solutions to have an impact and save lives for the opioid crisis. This is so exciting. All of the teams who've been a part of this, and it's gradually gotten narrowed down, but all of them have put in tremendous work and really come up with great solutions. We've narrowed it down now to our finalists for each of the 4 tracks. I'm going to just give a quick overview of the 4 tracks, and then I will hand it over to Ariel, who will introduce the teams for the final pitches. So track A is focused on developing software infrastructure or application interfaces for ethical and secure sharing of opioid-related data among different key stakeholders. So software for patients and families, for researchers, for policymakers, for each of those different stakeholders. Track 2 is focused on designing personalized behavior change applications, software apps that can be applied by patients, families, and/or providers or health systems for long-term reductions in overdose-related risk behaviors. It's focused on behavior change. Track 3 and 4 are our data science and visualization tracks. Track 3 is focused on real-time prediction models and visualization tools to prevent addiction and overdose. And track 4 is very similar to track 3, but focused on integrative therapeutic benefits and approaches to prevent addiction and overdose. The main difference of track 4 from track 3 is that track 4, a requirement of track 4 is that the teams integrate some new alternative integrative approach, such as cannabis, yoga, virtual reality, augmented reality, Google search data, some non-traditional public health or medical data source into their analysis. Now with that, I will pass it to Ariel to be able to introduce each of the teams, and we're going to do the pitches.
Hey everyone. So we have two really impressive teams competing in track A. First to present will be Group 21.
Hi guys, we're team number 21 and we're super excited to be here today. I'm Anna Dalzamon. That's from that side to this side. That's Nardos Magursa, Santosh Kanchala, Tom Huang, and Lance Hunter. Today, this is gonna be funny. Today we're really excited to show you guys our solution, Nopioid, which is our approach to how to help fight the help fight the opioid crisis. So as we know, the problem is that despite all the efforts, it's really hard and there's no effective way of combating the crisis. The hurdles include reporting lag times, lack of detailed information, lack of actionable insights. So our goal is to provide a unified platform where all the stakeholders can securely store and retrieve relevant data. So the current situation right now kind of looks like this, where each of the stakeholders are doing their part and they're collecting the data, and the problem is that because they're using their own systems, it ends up as data silos, where it may be easy to access your own information, but it's really hard to share that data across the key stakeholders and collaborate with them to work together towards a solution. So our solutions to this is to provide a solution where key stakeholders participate in a decentralized system where they're able to store and retrieve secure, encrypted, immutable data by using a private blockchain ledger. And all of that data will then be available in a dashboard, which will also include data from other resources and be equipped with role-based access control. That's saying that if you're a physician, a pharmacist, a police enforcement agent, a public health official, or a researcher, you guys have the same source to turn to, but based on your authorization level, a different access. So whereas a physician may be able to see the name of a patient, the researcher will only get the de-identified version of that same data. So what this allows us to do is by having one source for every stakeholder to turn to, it basically arms all the stakeholders with everything they need. And now they can take the right action steps. So physicians and pharmacists can pay better attention to patients based on that what they can see, and basically watch out how they're prescribing opioids. Researchers have a repository of personalized, de-identified data to do studies on, and then health departments can look at this and see where it is in which areas can they set up more intervention methods or support programs, or maybe safe disposal, because I know that's a big issue with opioids. And of course, the police, they can be better aware of what's going on. So benefits of using the solution is it's real-time data, it's digital transactions, it's data integrity and transparency. While there are benefits, we are aware that there are barriers that we need to be aware of. So of course there's the basics where we have to make sure we're HIPAA compliant and any other regulatory things. Of course, costs and time constraints. We understand fully that this is a multi-party negotiation. There are multiple key stakeholders who all have their own ways and regulations in life. So we have to work with each of them to figure out what is the best solution. And also we have to figure out, we have to make specific decisions, like what blockchain provider would be the best for this case. Second, another thing that we have to consider is how do we incentivize relevant parties today to participate in this? So this is where we did some research and we looked up that California recently had to mandate a Cures 2.0, where now physicians have to report how much opioid they've prescribed to Cures 2.0. This solution could actually be used as an extension to that itself, or even potentially, if similar situations come back, this is just going to be there as an option. So for today, we've actually prepared, because the number one, so why we're committed to this, of course, is because this is a major, major crisis, and it's affecting every individual. I think from all the symposium in the beginning, we all know that nobody escapes this. And so this hackathon actually gave us an opportunity to present the strategy that we know we're capable of implementing. And so we have the tools, we have the expertise, and we hope that if our ideas can be transformed into reality, we can save lives. So for today, we actually prepared an interface for multiple of the key stakeholders. We have an interface for the physicians and the pharmacists. We have what could be a researcher's portal. We have a patient app that uses IoT wearables and sends that information to the blockchain and IT. We can also show the blockchain actually doing the de-identification, masking that personalized data. So we probably don't have that much time, and we'll only show the physicians and pharmacists dashboard.
So here we have the login screen for doctors. So I'm gonna log in real quick as doctors. One sec. Let me refresh the page real quick. There might be an internet connection issue. Let's see what's going on. Okay, I can play the video real quick. So as I was going to do, I'm just gonna log in as a doctor, and quickly I'm showing the doctor's dashboard where you can see quickly the your visualization of your patient specifically. And here's a calendar of your just daily jobs. And Lance just walked into my office, and he's asking for more fentanyls. And here's a Lance page specifically, and I was gonna prescribe fentanyl, but the system automatically checked the blockchain network and showed an alert showing that Lance just recently was prescribed opioid drugs. So I'm just gonna prescribe 4 doses for 4 pills, so he doesn't overdose. And once I prescribe that, I'm gonna log in as pharmacist. So Lance is taking that prescription to the pharmacist where he tries to get the pills. So logging as pharmacist, and on the pharmacist screen, you can see all the active prescriptions that he needs to fulfill. And that's the fentanyl I just prescribed. And here I'm showing quickly a view of the report on the blockchain. So as you can see, the fentanyl is on the blockchain right here, and the status is still waiting for the prescription to be fulfilled. And I'm going to click on that to actually see the blockchain right now. And there's only one transaction since we just prescribed it. Now I'm going to go back as a pharmacist and actually click on fulfill and quickly refresh the blockchain page, and you can see there's another transaction that shows that prescription was fulfilled. So it quickly shows all the data are immutable. It's on the blockchain. We can trace back to when the prescription was filled, and all that information is secure. And
So just like this, like I said, we had the dashboards for a couple other ones. You guys just saw the physicians and pharmacists. We also had what would look like the researchers portal, and we also had a patient app that they could use. Basically, we tried to come up with an interface for each of the key stakeholders, because in this way, if we're able to connect all the key stakeholders with real-time precise data, then they can have all the things they need to take the right actions and potentially save lots of lives. Thank you.
any questions?
One second, please. I want to make sure that you guys know. My question was about your experience in the real world. in cryptocurrency or in blockchain?
So cryptocurrency, I personally don't purchase anything like that. I have done a lot of programming with Hyperledger Fabric, which is the method we're kind of going with a more private blockchain instances instead of with the like public, going with Ethereum or the other like public nodes, because we want to have a network that still operates in the same distributed systems and still has the same immutability and security, but have it private within the held by the stakeholders. So it's not necessarily going to be a public blockchain. So.
I understood that. Thank you.
Thank you guys for that presentation. I wanted to ask you a little bit about the physician and pharmacist interface. How is it different from what the Cures 2.0 interface is like? Because as a physician, it looks very similar. Are there going to be any other additions or benefits from the physician level interface?
So the benefits include the blockchain solution, because once they fulfill the prescription, it automatically stores that information in the blockchain, which the information is available to all remaining stakeholders. At this point of time, pharmacist needs to use Cures 2.0 portal, and then I think they need to enter how many pills they prescribe as a part of the day, but this system can help in directly, pushing that solution to the blockchain, which basically they can get a real-time information.
Yeah. And right now, from my understanding, physicians are required by law from that mandate to look at the Cures 2.0 database, but this, they don't actually need to go look. It will automatically notify them that this was already prescribed within a certain time. Do you know what I'm saying? They don't actually, it's like the taking out the human factor of it.
Yeah. I believe that's our time. Is that right? You're
Time. Okay, sorry.
Thank you.
And we don't have time for one more question.
No. Okay, thank you. Just a reminder to all the teams that you have 5 minutes to present and then 5 minutes for questions, okay? And also to not touch the mic because of the recording. The next group we have is Team 11.
Good afternoon, everyone. My name is Dr. Alan Young. I'm here with my teammates, Brandon Howard and Sherry Shea. Two of our teammates couldn't make it today, but they worked feverishly all weekend to put together the solution we're going to share with you today. So, as a physician, one of the things you heard earlier is really the challenge of having the right data to make decisions. And I think we've heard about potential solutions to store data, but our solution really looks at what data is going to be stored and how can we use that in a way that takes off some of the burden off of some of the providers and organizations such as government, pharmacists, police enforcement, et cetera. How can we store this data and be actionable on it? And so that's, I think, one of the things we're going to focus on is really the security of the data, but also how we use the data to promote behavioral change in our most at-risk patients. So our solution is going to be looking at securing data on the blockchain, but in addition to that, we have an end-to-end solution involving hardware and software that ties together not only interventions that we can put forward to help patients, data-driven decision-making to enable providers to help manage their patient population, as well as tying in the ability of resources for government, both at the federal, state, and local level. One of the things that we really focus on is being able to identify behavioral indicators that will signify if a patient is about to overdose on medication. So it's great as a provider to have information in a database that tells me how many prescriptions a patient has, but he or she may still obtain the medication illicitly on the black market. So our solution actually ties in sensors and other indicators that allow us to do predictive analysis using AI and machine learning to provide life-saving interventions based on this data that's stored on our platform. So our solution really is tying in a number of different things that we think is critical to move forward. A, the data will be secure and compliant. You heard a little bit about blockchain. B, the data will be actionable, meaning that will be available in real time to all the users. And C, really is going to be using a couple of additional tools and techniques that will allow us to determine an individual's behavior and their likelihood to use medication, and also their response to medication, which I think is a key indicator for what will happen to a patient if they're taking the inappropriate dosage of their medication.
All right.
So, getting into our solution. So, iPill is designed to keep, the prescribed opioids safe. So, we're going to describe this through a patient experience. Patient comes in, they're in pain, they fill out a questionnaire. That's one set of data that we're going to use to start analyzing potential behavior patterns for a user, for a patient. And so from there, they talk to the doctor says, okay, you need opioids, let's prescribe you some. But with that, we're gonna say that you have to take it through iPill. iPill is gonna regulate how often you get pills and the time that you get that. And so in order to make that process safe, usable, to collect the data, and to share that data through blockchain, there's a 4-point authentication process to link your cell phone to this particular dispenser, so that way only you have access. And from there, depending on the risk level of the patient, the doctor may say, we also need to check your breathing level. So starting to use more devices to collect more data, one that creates sort of a free-flowing experience for the patient so they don't feel interrupted. And at the same time, we're collecting that information because when this reaches a certain level, when somebody's breathing is irregular or stops, there's no one there to call 911. So the app is going to include a lot of AI and algorithms in order to be there for the patient, whether it's voice activated, whether the patient's journaling information into it. But the whole goal is to prevent diversion, overusage, and to monitor the patient's health and to be there for them, in case of emergencies. Next slide, please. Is it this? So the behavior modification. So after they have registered their iPill, their phone is linked up, they go through the process, they get their pill. What happens when they click the pill and then it says, okay, you're out of time? Or you have to wait another 2 hours? Sure. Okay, so long story short, the AI will give the patient options in terms of things to do. And we have a few options there in terms of communicating with groups and family, emergency contacts. Euphoria is a binaural beat, brain sort of behavioral augmenter. So we're getting into a lot of the AR and the VR, but basically using sound and color to stimulate states of consciousness. But sure, we can go to questions.
I'm a drug addict. Not really, but I'm a drug addict. I got a hammer. I'm going to break that device. How do you keep that from happening, or what's the penalty?
I mean, this device?
Yeah.
This
Well, let me be sure I understand. That device is actually the dispenser, right?
Yes, this is a iPill dispenser, and it's actually tamper-proof because we lined it in non-toxic gel inside the lining. When you try to break it, it will render all the drugs into a undigestible glob.
Thank you.
You're welcome.
Yeah, I have a quick question. So I saw that some of your interventions are social-based. What about routing to community interventions that may be through a nonprofit or some subsidized grant-funded entity? Are those included in that?
Well, actually, this device we have already pre-marketed to Anthem Blue Cross, Blue Shield, and Express Scripts. And then they have expressed that we proposed to them a value proposition. With the $30 worth of iPill dispenser, you can save $12,000 worth of emergency room visits. So $30, $12,000. So we pretty much pre-sold this iPill dispenser to them already. So the insurance company, they're willing to pay for iPill dispenser with not adding cost to the patient.
Okay, I'm sorry. Let me rephrase my question. A community intervention provided by a nonprofit organization that may be behavioral modification support and a intervention that may be a public health intervention.
Sure. So you're asking what of our presentation can cater to that kind of intervention? So the behavioral modification aspects that we are offering, they're available for dissemination now in terms of the Euphoria app. It's just one method. It's currently available. The ability for it to be implemented on any scale on a community level. As far as the app goes, behavioral modification aspects of the app, those are Euphoria is available, it can be enhanced. We can start to work with communities to figure out how can it best work on a larger scale. But essentially right now, it's already collecting data on like 250 patients on a regular, every day, and it's monitoring their moods as, point in time data, allowing us to start to map out behavioral patterns for individual patients. And as we aggregate that data through blockchain and Blockpoint, we can start to get into the predictive nature. Our goal for this track was all the data that we can collect. We see a lot of potential in what everybody else can do when we have point-in-time data for patients that's scalable from your community to government level information. Does that answer your question? Okay.
So this, thank you for your presentation. So the breathing apparatus, the breathing wearable or whatever it is, can you tell me the physics behind that? I'm interested.
Sure.
Or like what do you mean by breathing and where is it placed?
So it's going to be an external sensor that will pick up basically respiration through the neck. So if you think about the airflow through the trachea, it'll be tracking the patient continuously and it'll correlate it with their status, either they're sleeping or they're exercising or they're waking. Respirations per minute, basically due to depression. Respiratory depression is an indication of potential overdose, and that will trigger our algorithm to indicate a workflow process that would notify emergency contact or other stakeholders or other family members as well to try to intervene.
So they're wearing this 24/7.
Correct. It's like a patch, like a sensor patch on the neck.
Thank you.
Thank you.